Welcome, everyone. It's 7 o'clock, and I think we'll get started. I'd like to start with a land acknowledgement because we're meeting on the lands of the Coast Salish peoples. This is where I am, so please take a minute to acknowledge the peoples and the lands where you are joining us today. We are engaging in efforts to achieve equity in healthcare. We ask that you reflect on the inequity that affects Indigenous peoples because the lands on which we reside have been stolen from them. We acknowledge all of the ancestral homelands and traditional territories of Indigenous peoples who have been here since time immemorial. Our efforts to achieve equity in healthcare, the work that Healthcare for All is doing, includes universal healthcare coverage for the Coast Salish peoples of this land, the land which touches the shared waters of all tribes and bands within the Duwamish, the Puyallup, Suquamish, Tulalip, and Muckleshoot nations. So thanks for taking a minute to acknowledge that very important factor. Tonight, we will be addressing the combination of healthcare, but with housing, with community-based solutions that is going to be that the factors that have to come together in order to end homelessness. So we will not end homelessness tonight, but we're moving ourselves in the right direction. We've asked a couple of guests to join us tonight before Nancy's talk, and I'd like to start with Frank. Representative Chop, I don't think you need any introduction. A very powerful voice for healthcare and for a number of other factors in our lives. So why don't you talk about what's happening today?
Well, thank you very much, Ronnie. Just to check the volume, am I loud enough or too loud? Is it
You
okay?
are
All right, great.
just perfect.
Thanks. I've been on so many Zoom meetings today. I just want to make sure it comes across well. Thanks for the opportunity to talk with you tonight. You got a great turnout. I also am honored to be at the same program with Nancy Connolly. I've read a little bit about her background, and actually, I'm surprised we haven't met necessarily formally before because we're working on many of the same issues. I'm not a doctor. She is, and we can learn a lot from her, and so glad to be part of that program. So, at any rate, what I'm here for is to report about the legislation that has a real interesting and exciting dynamic going on. I call it Apple Health and Homes. It's House Bill 1866. That's 1866. Which basically tries to make the connection, a very strong connection between healthcare and housing. There are thousands and thousands of folks who are suffering on the streets right now, and I can't abide that. None of us should abide that. We have folks who are suffering and dying in many cases, and we ask the question, why are people chronically homeless? Well, based on the studies and the research, over 70% are there because of their healthcare condition, mental health, mental illness, substance use disorders, also large or serious physical disabilities. And we have got to draw attention to the reason why they are, and many of them are chronically homeless, and is because of their healthcare condition. And we want to make sure that that is emphasized because that's the way to deal with this program into the future on many levels. So we are very pleased to say that the bill, which is a very significant bill, has already gotten out of healthcare and wellness unanimously, also out of the Appropriations Committee unanimously. And part of that is that the Republicans have finally realized that they have family members or friends or relatives who have mental illness and substance use disorders, etc. So I was blown away when they actually voted for it unanimously. That helps build momentum for this and also sustains the future because we want to make sure that this program is implemented over the next few years. Essentially, what we are doing is try to build on currently successful programs. There's a program in the Healthcare Authority called Foundational Community Support Services. And it's based on, for those who follow this kind of detail, It's based on an 1115 federal Medicaid waiver, 1115 Medicaid waiver. But essentially, the feds have agreed to match funding for the Medicaid program, which in our state we call it Apple Health. I think that's a better thing than a bureaucratic name. I came up with that Apple Health name so many years ago, and it's very successful. But we want to make sure that we recognize that that federal match only covers some support services, but not the actual home. So if you are eligible for foundation community supports, you have to meet the certain medical conditions. And if you meet those conditions, in my opinion, you ought to be guaranteed a home as part of your health care treatment in response to your medical condition. It's like, if you are on Medicaid and you have a stroke, for example, and you go into the hospital and they roll you into the MRI, they don't sit around trying to figure out how to fundraise for that MRI machine. It's just part of the benefit package, and people, get the services they need through Medicaid and through the Apple Health program of Washington State. So we are also building on all the effort we've done to build a significant number of housing folks for this population, and to do it in a way that's called supportive housing. So it's the individual gets screened, they're eligible, they'll get a house, and then there will be some ongoing support services that I think Nancy will talk far more about that than I could. But I just realized that to ensure the success of this incredibly serious societal condition, it's best served and best solved by having it part of healthcare. So I appreciate your awareness of this. I also wanted to say that we've done a lot of outreach to people. When we had the first hearing on this, we had over 300 people sign in support. We have over 50 major organizations endorsing it all across the state. And we have real momentum to do this. As part of our proposal, we not only want to pass this law, but we also want to get $400 million assigned from the federal ARPA funds to jumpstart this effort to acquire more housing for this population. Currently, there's 5,600 people that are registered eligible through foundational community supports, and through a combination of things, we've already leveraged quite a bit of money to start this effort. For example, I passed a bill a few years ago to get $400 million in bond money to King County, and they have used that money to actually buy up a bunch of hotels, which then people are being taken care of, and instead of them on the street or in a park or whatever, they have a home in the hotels. For example, up at 141st and Aurora, King County bought a hotel there, and so literally people have been moved out of homelessness into the hotel, and then they have support services there. The thing to keep in mind, which I think Nancy probably could build on, is that this is not going to be a cheap program, but is a hell of a lot cheaper than the current situation. You can see through that 2-pager where we talk about the percentage of people cycling through emergency rooms, hospitals, jails, you name it, and that costs a lot of money. In fact, it's cheaper by about $46,000 per person in terms of if we do it this way, the right way, where we provide medical care for them and a home, a decent home. It's far cheaper than the current situation where they're suffering and dying on the street or taken through the healthcare emergency system. So we're very excited about that. We would appreciate any questions you have. I don't want to cut into Nancy's time too much, but I'm really excited about this. We have got to do this new dynamic to make sure we put it in the context of healthcare. And then I ask the question, who is responsible in the state to provide healthcare for those who are less fortunate and low income? It's the state of Washington, not a local city, for example. So putting in this context will leverage more public support because people realize that there's a real crisis out there in terms of mental illness and substance use disorders. They get that, and that ought to be provided with state funding to go forward. Ronnie, I could go on for another couple of hours, but I think I'll end at that point. So thank you so much for inviting me. It's the end of a long day. Usually I'm getting even more excited about this thing. So I'm like, I just think we're on the right path. And also I want to say that I'm working closely with Nicole Macri, the state representative from the 43rd, and also Eileen Cody, the chair of the healthcare committee. And we were just like that, united in this whole effort. And there's a good chance we don't take, it's a good chance to pass it. We don't take anything for granted, though. So thank you, Ronnie, so much. Any questions or comments?
Yes. Randy Knob asks, why are the initiatives focused specifically on the demographic of houseless youth in so many communities? A special note, rural counties and community resources to address this segment of homelessness lack many of the resources that metropolitan areas do.
Well, we actually have developed partnerships with a number of local communities all over the state, including relatively rural areas. In fact, one of the community agencies is the Coastal Community Action Program. They have a program for foundation community supports. They actually have what's called a Pathways project there that is a great success, and we're partnering with them to not only provide them with the funding for the services, but also funding for them to acquire housing or apartment building or a hotel or build new to house the folks, and then also provide medical and other social services directly to them on site. So we've got that. We've also got a lot of interest from Yakima, with the Yakima health clinics over there, also Spokane, Vancouver, etc. I mean, the outpouring of success or support for this thing is pretty astounding.
Well, thank you, Representative Chop, for adding that. We talk about the medical issues involved in people's health care. We talk about social determinants of health, but
Yes.
the political determinants of health are really critical. Those decisions that we're making at the state and county and city level really have an impact on people's health. So thanks for being a champion for the people out there that need it. So thank you again.
Thanks, Ronnie. I appreciate this. If you don't mind, I'll sign off after a few minutes. I'd like to hear Nancy for about 10 or 15 minutes, but then I'll go on back home to get something to eat.
All right,
Okay.
and you can watch it later on YouTube for the part that you missed. So I'm sure she'll add some important facts to help support what you're doing for us down in Olympia. So thanks. It's people have joined since we first started. Just to make a couple of points of information, we are asking you to put your questions in the chat. We have some volunteers that will lead a discussion of those questions after Dr. Connolly's presentation. We ask that you put your full name on your name section. Rename yourself with your full name if it's not there, just so that we can communicate clearly. And we will be entering information in the chat. I entered a PDF that that Representative Chop shared with me earlier. I'll enter that again later on in the meeting, so look for that PDF if you missed it earlier. And we also will be entering the donation site. If you are able to make a donation to Healthcare for All, please do that. That link will show up in the chat. So, Nancy, I'm going to ask you to unmute and pull you up on the screen for 1 minute together, and then I'll open up your PowerPoint to get started. Nancy, Dr. Connolly is spent the last 4 years working with the University of Washington in their Harborview downtown programs. She's partnered with homeless service providers at the Downtown Emergency Service Center, at Compass Housing, at Pioneer Square Human Services, and with King County Healthcare for the Homeless Network, and has been providing care directly. She's been out there carrying the barrier for all of us. And this is a multifaceted problem. There's so many issues involved in healthcare and for people that are in need of housing. So it's exciting to have you join us tonight.
Okay, well, thank you so much, Ronnie, and thank you, Representative Chop, for being here and for all the great work you've done, and for Bill 1866, which I have signed in pro for myself individually and for my organization, Doctors for America. So I appreciate all the work that you've done, not just this bill, many others. So thank you again. And I want to just start out by saying that I've been fortunate not to have spent the last couple years on Zoom, and I will acknowledge that I'm a little bit of a nervous speaker. So I hope you can bear with me with this. It's something absolutely I'm working on. So I want to start with a short metaphor that is very meaningful to me. And in fact, was part of the reason that I moved to Harborview downtown programs. And in this metaphor, 3 friends come down to a raging river and find many people struggling in the water. The first friend immediately jumps in and begins to pull people from the water. The second friend sets to work building rafts and finding ropes to help people stay afloat long enough to get to shore. The third friend, seeing what the others are doing, begins to run upstream. The first 2, seeing their friend running off, shout out, "Where are you going? There is so much work to be done. We can use all the help we can get." To which the third replies, "I'm going to see if I can find out why they are falling in and fix that." I spent the first 10 years in Seattle working at Virginia Mason as a primary care doc in Linwood, at the latter half of which I was the medical director of that clinic. I provided primary care to many people like you and me, like all of us. There are many frustrations in primary care for primary care doctors these days, and I bet you guys know some of them. Doctors are being asked to see more and more patients in less time with more administrative demands and less support. I could see my doctors getting burnt out, and I could see we weren't doing enough for our patients. We were treading water and things weren't getting any better. I was hungry for a different way. The clinic in Linwood was really a midstream kind of place. Some people were sick while others wanted help staying well, and I could often help. But I couldn't change the turbulence downstream, and I had no agency in the conditions upstream, even as medical director of my clinic. With my kids growing up and needing me less, I wanted to do more. And so it was my plan to move upstream. Perhaps unsurprisingly, spending 10 years as a primary care doctor, caring for 15 to 20 patients a day, isn't exactly a resume for working in a position where there's the opportunity to fix upstream systems. Trying to move in that direction, however, I took a job at the University of Washington to surround myself with people studying the issues in a position where there was certainly a lot to learn and hopefully meaningful work to do. My first role at the university was at the sobering shelter, pictured here, the Dutch Schisler Sobering Center, which was at the South Lake Union part of Seattle. What I did at sobering certainly had a lot of meaning to me, and in many ways, it was more satisfying than the work I had been doing. Since it was a grant-funded position, I wasn't dependent on volume-based revenue, as most doctors are, and I had more time to really get to know my patients. And the people that use the shelter, not all patients, but all people I interacted with, the people that used the sobering shelter really liked it because you didn't have to worry about showing up at a particular time to get a bed. You could come in any time, day or night, and your stuff didn't get stolen because all possessions, including shoes and belts, were handed over to staff and locked in a closet. Also, the mats on the floor were monitored, so fights didn't break out. It was just a place to sleep. It attracted a certain community, mostly, but not exclusively men. The sobering shelter was funded by local businesses so that if they had someone asleep in their doorway, there was a van to call who would come and bring the sleeper to the shelter, usually without involving law enforcement or emergency services. Getting to know my patients had a downside, however. People who are homeless have a much higher mortality and die at an earlier age than those people with stable housing. Next slide, Ronnie. I worked at the sobering shelter from November 2018 until June of 2019, when, for administrative reasons and general disorganization caused by the messy interactions of multiple organizations, the left hand not talking to the right and failing to coordinate the many pieces required to move it, the sobering shelter closed, and as of today, has not yet been replaced. During my short tenure there, my first, second, third, and more patients died. We lost on average one person each month. The first person was a gentleman that I met over coffee more than I actually treated as a patient. Though Derek stayed most nights at the sobering shelter, I never saw him intoxicated. He was confined to a wheelchair, was mild-mannered and quiet, and played a good game of chess. when he could find someone, usually our milieu manager, to play with him. He was found early one morning at the Soto light rail station, possibly riding the train to stay warm, exiting before closing and unable to get off the platform. Another man in his late 30s was found just a block away from the shelter, dead from alcohol intoxication from drinking a bottle of cooking wine, something popular at the time, the cheapest way to prevent alcohol withdrawal seizures and available for purchase with SNAP benefits. Next slide, Ronnie, or next click, please. Mortality amongst the homeless is high. According to the National Healthcare for the Homeless Council, on average, people without homes die 30 years sooner than people with housing, and they are 3 to 4 times likelier to die of any cause than those with homes. Next slide. When Sobering closed, I moved to the largest downtown congregate shelter run by DESC, many of you know, Downtown Emergency Service Center. That's pictured on the top right. That's the Morrison Hotel. It was opened in 1979 and served people until it closed and the population moved to the Red Lion. That shelter housed about 200 people in 2 large dorms and about 3 smaller ones. There was a men's dorm, which housed a little bit over 100, I think, a women's, which was about 80, and then were 3 about 12-person dorms in there. I learned about the huge variety of shelters, each with slightly different rules and conditions and slightly different groups of people that gravitated to them. Operation Night Watch serves everyone a meal and tries to find beds, usually in church basements around the city, to those that show up at a certain downtown spot each night at 9. The Salvation Army runs shelters where you show up at 7 in the morning and put your name down and hope for an empty bed. Many shelters, particularly now, require a referral. St. Martin de Porres, we call it St. Martin's, run by Catholic Community Services, was, before the pandemic, mostly mats on the floor for men, some of whom lived there for years. During the pandemic, they pivoted to hotels and new shelters that have individual spaces to allow for social distancing. Mary's Place is, as far as I know, the only shelter that allows families, men, women, and children in family units to stay together. Most shelters will not permit men and women in the same room, regardless of partnerships. Many shelters don't allow pets. Tiny houses are shelters and should never be mistaken for permanent housing, although it is true many people can stay there for some time. Most shelters have curfews, and until the pandemic changed things, most shelters opened at night and closed in the morning, with most people having to carry with them all the possessions they own. Most of the people I know frequently had stuff stolen, and a large part of my time in the main shelter was spent replacing lost and stolen medications. At the main shelter, there was one day every year in the summer when everyone was removed for a 24-hour deep clean, the joke being whether it needs it or not. There was one woman in the main shelter that hadn't been outside at all. I mean, she never left the room for decades, really, until the pandemic forced her to move to a hotel. This woman, along with some others who were particularly fragile, were given dispensation for the deep clean day. Next slide. This is one of the dorms in the Morrison. This was the men's dorm. When I was there, I never saw it looking so clean. A couple of women I met, sisters in their 60s, were sharing an apartment prior to being homeless. One of them became ill and they were unable then to afford the rent with just one salary. They went to the shelter. In conversation, the one who hadn't been ill told me that she'd worked all her life, still was working, in fact, as a caregiver. She worked in Issaquah and told me the best part of her day was that bus ride. She told me that the hardest job she'd ever had was simply living at a shelter, staying clean. Showers were communal, and not having your stuff stolen while you were showering was a job in itself. Those women ultimately got housing in a senior building, but it took 8 months to figure it out, and it was the opposite end of the city from where they'd started. I was working in the main shelter when the pandemic hit, and this was an absolutely fantastic experience, as I was able to see in real time how being provided with a door that locked and a private bathroom made a world of difference to many people. Things that were prevalent before, like lice and bed bugs, diminished dramatically and immediately. People who had been paralyzed by anxiety began slowly to relax and to heal. One sweet elderly gentleman told me that he couldn't remember the last time he'd slept in a bed with sheets. I saw mental illness improve and several people got jobs. Next slide. One thing I see, though, is that housed or homeless, people's needs are remarkably similar. which isn't to say that those that are homeless don't have a harder time getting those needs met, but the need for purpose and social connectedness, essential elements of health, is universal, and for many people in our modern society, elements that require work to achieve. This is as true in a conventional clinic as it is in a clinic embedded in a shelter. Next click. So the World Health Organization defines health as not merely the absence of disease, but a state of complete physical, mental, and social well-being. That's hard to achieve with stable housing and virtually impossible without it. Next. The World Health Organization further states that it is the fundamental right to have the highest attainable standard of health, something I think we fall far short of in this country, despite our stature in the world. Next. They further state that the peace and security of all of us is dependent on our cooperating to achieve this standard of health for everyone. Next. Which brings me to the social determinants of health. There are many names and many diagrams for the social determinants of health. There was a bloom in the mid-70s with Dr. George Engel describing a biopsychosocial model. It wasn't a new concept then. In fact, Dr. Rudolf Virchow wrote in Germany in 1840, if medicine is to fulfill her great task, then she must enter the political and social life. Do we not always find the diseases of the populace traceable to defects in society? I like this schematic from the Bay Area Regional Health Inequities Initiative because, unlike some, if you look all the way to the left, no, go back, Ronnie. Back, thank you. If you go all the way to the left, they list the inherent power structure into which we are born and call out social inequities arising from race, gender, identity, immigration status as impacting our health, directly impacting our health. Moving to the next box, the institutional inequities. These impact our health as well. The schools, libraries, and businesses we have access to impact our health. Next, and most germane to our current conversation, not only housed or not, but quality of housing and whether or not there is violence or toxic chemicals in our surroundings, what retail businesses we have access to, whether or not we experience racial discrimination in our daily lives, all have direct impacts on our ability to achieve health. The lack of safe and secure housing is quite clearly a significant factor that impacts a person's ability to achieve complete physical, mental, and social well-being. In our current system, doctors are typically pigeonholed into the final three boxes, with only primary care doctors generally expected to work in the risk behavior box, coaching people to use their individual resources to eat well, exercise, and avoid unhealthy behaviors. Placing the onus on the individual to seek out healthy foods and opportunities for exercise and ignoring society's responsibility to make these things the easy choice rather than the one we have to fight for. We know, however, that most of us do little to earn the health benefits that come from the first three, four, perhaps four of these boxes, and that really this is the lion's share of whether or not we are healthy. For 80% of health is the social determinants of health. For those people lacking everything, we are generous enough, that's facetious, to provide disease, injury, and tertiary care services, often at a cost, for those our society has denied the basic building blocks of health. I believe that we need to work as a society, with all of us helping to make it easy for people to have health. We do this by working to reverse inequities in all sectors and by ensuring that everyone has access to safe, violence, and toxin-free homes, easy access to healthy foods, and the time to nurture relationship. I believe this is the role of government, to make it easy for each and every one of us to have the basic building blocks to live a healthy life. Next. Next, I'm going to tell you a little about the research I've been reading in my spare time while I've been spending my days working with people living in the shelters and outside. Next. Next, Ronnie. The Pathways Housing First model was started by Dr. Sam Sambaris in New York City in the 90s. It started as a drop-in center which welcomed consumers without the prerequisite for sobriety. This was largely consumer run and was successful at empowering people, but didn't initially provide housing. Next. Dr. Sambaris then founded Pathways to Housing using funds from the city and state of New York to provide housing to people with serious and persistent mental illnesses and long histories of homelessness. Pathways Housing First provides consumers living on the street with immediate access to apartments with private landlords without prerequisite for sobriety or participation in treatment. Wraparound services offered 24/7 and consistent of multidisciplinary, what's called assertive community treatment teams, consist of peer counselors, nurse practitioners, vocational rehab specialists, and psychiatrists, are voluntary. The point of the services is not to enforce sobriety, but rather to ensure that substance use doesn't interfere with one's ability to meet other goals, such as maintaining housing, getting employment, and rebuilding relationships. Key features of this model that are believed to make it successful are the centering of consumer choice, whether to live in a conventional apartment, communal housing, or sober living, or permanent supported housing, which I'll talk a little more, as well as the assertive community treatment. In all the studies I've read, assertive community treatment is a very big factor, where a team is assigned to check in on people and help them when life becomes complicated. Recall that these types of initiatives are very hard to study. They require quite a lot of money and generally not from the traditional sources that fund studies. Next slide. Ronnie, next. I initially learned a lot from this great book, In the Midst of Plenty by Shin and Kaduri, published in 2020, which discusses and consolidates a lot of the research. It's a great reference and starting place to understand a lot of the data. Next. Next. There you go. The only rigorous study for many years was Dr. Tsambara's own study, until it was replicated in Canada at the at-home chez soi model, where it also demonstrated success with over 2,000 participants. Now, I want to say a quick word about what success is. I put a lot of thought and study into that question, and I'm going to talk about that more later. Next slide. Around the same time Dr. Tsambara was starting Pathways, Dr. Roseanne Haggerty founded an organization called Common Ground Community, which is now called Breaking Ground, to demonstrate a solution to homelessness at scale. This was the beginning of permanent supportive housing, which is different from Pathways Housing First, which provides on-site services and rooms at affordable rents to those people who are most vulnerable. Her project evolved. They split off. In 2003, noting that while more people were being housed in the new PSH, overall homelessness was still increasing. Dr. Haggerty then facilitated the organization of stakeholders in a defined area in Manhattan. This effort, which became the Street to Home initiative, was able to reduce homelessness in the area by 2/3 within 3 years and led to an 87% decline in homelessness in the target area and 43% reduction in the 230 blocks surrounding the target area. To make a long story short, sorry, does someone have something? No. To make a long story short, the group has evolved further. In 2021, they received a MacArthur Foundation $100 million award to accelerate an end to homelessness in 75 US communities that are partnering with them in the next 5 years. Next slide. Which brings me to the Benioff Homelessness and Housing Initiative, led by Dr. Margot Kuschel, which in their words provides accurate, timely, policy-oriented research about homelessness for local, state, and national policymakers and practitioners. They conduct research which is impact-oriented and aims to identify and advance policy solutions. They regularly consult with policymakers, recommending evidence-based solutions to key stakeholders and translate research findings into implementable policies and practices. I said a little earlier that I would talk a little bit about how success is measured. The metrics one chooses to measure are critically important when creating systems and policies. Traditionally, the metrics used are things like maintaining housing, cost of service, decreasing use of acute care services with commensurate increase in use of other types of services such as rehab, social services, vocational services, scheduled appointments. I've spent a lot of time looking for the best metrics. The one I found I like the best is something called community integration. It's great that people stay housed, and that is certainly a goal. But what we really would like is for people who are chronically homeless, who are truly living outside the mainstream society, become integrated into a society of their choice. Community integration as a metric is an example of an attempt to measure what matters and is composed of things like mobility, social relationships, such as do you have someone you could call in an emergency, home life, work, economic life, and community and civic life, among others. Sorry, my computer wants to update itself. Since homelessness and housing initiatives can be quite hard to fund and take a long time to study, this is and will be for the foreseeable future a work in progress. That said, this is something we can and should address now in ways more robust than we are currently doing. I do believe that in a reasonable period of time and the ability to be nimble, we can solve homelessness. Next slide. So in conclusion, I believe, based on my on-the-ground experience and fairly extensive study of the history and research of housing initiatives, that homelessness in our community can be eliminated. There are several things that need to happen to make that so. Every successful model I have read about employs a much higher staff to client ratio, including professionally trained social workers, case managers, and peer navigators. We need to prioritize that moving forward. Next, I want to say this is so important. I really need you to know that all the people working in the shelters, working for the providers at Catholic Community Services, at DESC, at Plymouth Housing, at Recovery Cafe, at so many organizations, these people are really the heroes. They do hard work for low pay and little recognition. We really need to support them in the work they do, not only with professional pay and benefits, including adequate staffing levels, vacation and sick leave, but also with training opportunities and providing them with the tools they need to better help their clients, including smaller caseloads, experienced mentors, and more mental health addiction housing options for those they serve. Next, we need to build resiliency into our systems, centering consumer choice, so important, with flexibility to choose from a variety of types of housing, not just studio apartments in purpose-built residences, but options such as conversion of underutilized spaces for communal living for those that choose it. Finally, we need to consider the provision of specialized housing, not only sober living, but also for single gender or for people who choose to live in culturally similar communities. When people choose their housing, they are more invested in making it a healthy place to grow. So I'm going to leave you with this quote from the Finnish model. Incidentally, the Finns have durably achieved what we would refer to as functional zero. Because their standards are so much higher than ours, they're still working on it, but we would consider them to have solved the problem. They did it by working with this basic assumption that a dwelling is not a reward that a homeless person receives once their life is back on track. Instead, a dwelling is the foundation on which the rest of life is put back together. Thank you for your patience with me, and I look forward to taking any questions.
Thank you, Nancy. So if you have further questions, please enter them in the chat now so that they can start to prioritize those. And I'd like to take a minute to just shift gears for 1 second, but I just wanted to thank you. I know when I drive down I-5 and see people living outside who don't have control over their lives, it just brings tears to my eyes each time, and so I'm sure we all share that. And it's great to hear that there's a direction and to stop and look at the underlying factors. So thank you.
You know, I want to say one thing before the questions, and that I'm so grateful for the work that Representative Chop does. To me, it's very important to note that mental health and addiction do not cause homelessness. A lack of affordable housing is the primary reason for homelessness, which is not to say that mental health and addiction are not related, but I don't believe they are the cause of homelessness. A lack of affordable housing is the primary cause of homelessness.
And that's certainly something Frank shares from each time he talks. So thanks for highlighting that. So I'm going to take you off the screen for just a minute while we put those questions together, and would like to ask Peter to Peter Lucas to come forward.
All right. So I'm Peter Lucas. I'm a board member and practicing physician. And thank you, Nancy, for that wonderful presentation. And you mentioned that mental health and addiction issues are not the primary cause of homelessness, but they do impact homelessness. And as a practicing psychiatrist, I can appreciate some of those things. But my role tonight is to let you know a little bit about what our organization is doing and ask for your support. And our organization has chalked up many successes over the past few legislative sessions in Olympia. We were the driving force behind the Universal Healthcare Work Group that led to the Universal Healthcare Commission that is meeting now. Many of the members of that group were people that we helped get on that group, and it's tasked with creating a system to provide healthcare to all Washington residents. And potentially they could craft a single payer system based on our bill, what's called the Washington Health Security Trust. But in order to maintain our momentum, it's vitally important that we grow our membership, educate the public, and mobilize our supporters to spread the word to their family, friends, and most importantly, their legislators. And we can achieve these goals through social media, monthly webinars like the one tonight, meetings with civic groups, and by hosting other events. And now that COVID is hopefully, fingers crossed, retreating in Washington and around the world, we plan to get out more from behind our laptops and smartphones and meet with people in person. In addition, we have a very dynamic and effective lobbyist who's been very busy lately, a communications specialist, and other fixed costs. These activities and obligations all require funds, which is why we are asking you to donate tonight. And as mentioned earlier, our goal is $500. So you can go to our website and click on the donate button. You can go to the chat, and there are several links to make a donation. You can make a one-time donation, but we would especially appreciate it if you can make a monthly recurring donation. I liken it to a Netflix subscription, except you might get universal health care instead of movies. So please donate so we can spread the word and bring about universal single-payer health care in Washington. Thank you so much.
Thanks, Peter, for verbalizing that for all of us. And I guess we hopefully won't be saying might, that we will achieve that goal. So thanks, Peter. Let's move you off the spotlight and bring in our questionnaire, or bring Nancy back in, and Marcia Stedman, who I need to find on the computer. If you could unmute yourself, and I'll bring you into the screen. And hopefully you've identified one question. Consuelo will be helping you in the background. Why don't we get started with the Q&A session? So, and please feel free to add more questions into the chat. If we don't get to all of them, we will put them together into a bulletin later on. Thanks. Marcia.
Hi, everyone. Thank you so much, Dr. Connolly, for your presentation. That we learned a lot tonight, and we have some questions. So first one is from one of our board members, Dr. Sherry Weinberg, mentioning in Europe, where countries have both universal healthcare systems and social support systems, how do they handle this area of mental health problems leading to social housing problems? And can we learn anything from them? I don't know.
So I will start by saying that I think it's less that mental health problems lead to housing problems than that a lack of housing problems allows people with mental health problems to fall through the cracks, if you will. So if you think of affordable housing as a game of musical chairs, When the music stops, the people least likely to get a chair are those that are most fragile. Those are people who are least able to advocate for themselves, i.e. those people with mental health and addiction. So those people that we see unhoused that have very high rates of mental health and addiction are there because there's no place for them to live. There isn't enough affordable housing. I mean, we need, I can't say that enough. We need more affordable housing. There's ways to get more affordable housing. We can provide more rent subsidies, and most European countries are much more generous with their rent subsidies. It's my understanding that of the people that qualify for rent subsidies, only about 20% of those people receive them. And so we need to bolster that process. My two women who I talked about that lost their housing because one became ill, they did not have mental health problems. They couldn't afford their apartment. I knew many people that simply became unhoused because they couldn't afford their apartment. There was one gentleman that I knew that was living in Green Lake for many years, walked around Green Lake every day, lost his housing because he couldn't afford it, and then he started drinking. He didn't drink before he was unhoused, or he didn't have a problem. He was perfectly functional, but jobless. So housing subsidies is one way, more affordable housing in another. In an area like ours with a very high median rents, we need people to be medical assistants and to wash dishes and to serve. And we shouldn't ask those people to have very long commutes. They should be able to live near where they work. We need them in our city. So we need more affordable housing. I'll stop there.
Okay, thank you. Another question, there's a question from Rich Legue, who asks, you have talked about programs that get people who are homeless quickly into homes, but is there a way we can prevent people from becoming homeless in the first place?
Yeah, absolutely. And I totally agree with that. You know, I would love to see a system of mediation, and I'd love to talk to people with more knowledge or experience of this. But if someone is at risk of losing their housing, I wish there was someone that they could call to help them troubleshoot, maybe to bridge a gap, maybe to find them a lower rent housing if they truly can't afford where they're living. I wish there was a way to prevent homelessness. Some of it's rent subsidies and some of it's merely, you know, giving people somewhere to turn when they feel they're at risk of being homeless. Also giving landlords a place to go, somewhere to call that says, hey, this person isn't working out. How can we help them without evicting them to the street? So I think building some infrastructure around that would be very helpful and could help us. I absolutely think it's probably the better bang for the buck to prevent homelessness. It's more expensive once people become homeless.
Thank you. And we have a question from Charles Mayer, who asks, what specific policies or laws are you advocating or hope to realistically see here in Washington to get us to be similar to Finland?
So thanks so much for that question, Charles. And, you know, I'll tell you honestly that this is something I'm learning. I think the Apple Housing to Healthcare initiative that Representative Chop is introduced is a good system. And what part of what that does is it uses the Medicaid system, the 1115 waiver he talked about, to harness Medicaid money to pay for this. Now, it's a little controversial because people think, isn't that money better coming from HUD or from HHS? The beauty of the Medicaid, using Medicaid dollars to help with that, is that Medicaid dollars are an entitlement, which means there's no cap on it. HUD and HHS, it tends to be a capped amount of money that comes in. So that's why this 1866 bill is a good start in that direction. As I understand it, the King County Regional Homelessness Alliance is missioned, their goal is to address the crisis less than it's to address the system as a whole. And I think, you know, we need to do more to look at the prevention and fill the cracks, if you will. There was an article in the New York Times this weekend that talked about the gentleman who was mentally ill and pushed the person on the tracks. And there was a quote in there that I really liked that, people are less falling through the cracks than we're shoving them towards the abyss. It's like we have islands of service and we need to build bridges between those islands. If someone's in a mental institute, if someone's in an ER, if someone's in a rehab, they should have safe discharges. And I think we can create policies to require safe discharges. So that's a partial answer, and I'm going to learn more. I'm always learning. Thanks.
Great, thank you. There was another question similar to that you've already sort of answered just now about is there a recommendation you have for hospitals and emergency departments when having to discharge someone with chronic homelessness?
Yeah, and I love that question because of course it's something that I see every day. And I think it's wrenching for people in emergency rooms to have to discharge people who are just out of a crisis to the street. We need, every time someone touches one of our systems, be it an ER, a hospital, a mental health institution, a jail, a prison, a rehab, we need to create a system where there's a safe place for that person to go. And that's something that I think is deeply lacking right now. And I think it's something we really need to put a lot of work into.
Mhm. Thank you. We have lots of recommendations from people who are here on the call tonight. So there's a huge interest in this topic.
So let's ask one more question.
May I ask a question?
Yes, please do, Consuelo. Go ahead.
Hi, so for years I worked with Interim CDA, which has a very robust homelessness prevention program. And I completely 100% agree with you. The focus has to be on not affordable housing, but housing that's subsidized so that people who are very poor that fall within that 400% can actually afford to live in them. Because affordable housing is kind of a catch-all phrase that doesn't do much at many times. So I was wondering though, in your experience, have you found that programs such as prevention and diversion, rapid rehousing and coordinated entry, have those kinds of programs have had efficacy in your experience?
So I don't have experience with all those programs. I have some experience with coordinated entry, which is very hard to navigate if you're a client. The intention behind coordinated entry was to make it fair for everyone, make one line for everyone. And in practice, it causes a lot of problems because if you're at the front of the line, you get the available room, which eliminates consumer choice. And it sometimes puts people in situations where they're unsafe or unsuited. For example, someone who may have schizophrenia is placed in the only available room, which happens to have people that are dealing drugs in it. It sets up an unsafe situation. And so I do think consumer choice is something we need to do a much better job on, allowing people to choose whether they want a group home, whether they want permanent supported housing, whether they want subsidized market rate housing. We need a certain amount of choice. I have seen, a really nice model that I saw sort of from a distance where there was an apartment building downtown where 10% of units were very low. 10% of units were set aside for people who had no income. 20% of units were set aside for people with very, very low income. These are all HUD definitions, right? There were 20 units set aside for very low income and the 50% was market rate. And I think that kind of a model is something that we could do with zoning and not to penalize landlords. Landlords are businesses. We need to respect, and we need to assure that there's housing for the people, for our workforce that are, doing the lower paid jobs in our city.
Thank you. And thank you, Marcia and Consuelo, for pulling those questions together. Thank you, Nancy, for really giving us the important background for this issue, for dealing with this issue, and for us accepting our own roles. So thank you. And just out of respect for everybody who joined us tonight, we're going to end in a couple of minutes. Let me just thank Dr. Connolly again for stepping out, taking all the time it takes to prepare something like this together and for doing it in such a moving way. Thank you. You said you weren't a very good experienced speaker, but you are right on spot. So thank you for tonight. Also like to thank Representative Chop for joining us and talking about a the really important underlying issue for this area, to Rich Lagu and Ron Lovell and Consuelo Echeverria and Marcia Stedman for helping with different aspects of it, for D.W. Clark for saving this video, which we will put on our YouTube channel. So if you want to share this with a friend, tell them to go to our website, click on that icon that says YouTube, and that'll go to our YouTube channel. So thank you. It's not too late to make a donation. If you can help support what we're doing, we'd appreciate it. There is a program we're planning on March 9th, on the third Wednesday or second Wednesday of next month, from Faria Mohammed from the Somali Family Safety Task Force. We'll be talking about a really important issue of healthcare, of helping to protect families and to give them access, another way to move in. So it's 8 o'clock. Thank you all for joining us tonight. Thank everyone who contributed, to our volunteers, and to each of you for joining us. Thank you very, very much.